Hey students, it's Dr. Turpin. I'm going to go ahead and finish out these last few slides for the lower GI content. I think we ended up on this slide talking a little bit about fistulas and talking how those are more common with Crohn's disease. Typically, you're going to see the same things we've seen for a lot of other things is when they have a draining fistula, often they're going to be put on bowel rest, meaning that they're going to likely be MPO. They may be put on TPN, IV for a period of time. If they have a condition where they have to have a large portion of the bowel removed and have short bowel syndrome, they may be required to have TPN for life. And then these patients tend to have chronic abdominal pain. These are just a lot of complications that you see from Crohn's and ulcerative colitis combined. And like I mentioned earlier, there are these extra intestinal complications related to these inflammatory bowel diseases, and they include things like having arthritis, spondylitis, eye inflammations, and skin lesions. And so because of that, even for the ones that have ulcerative colitis and have a huge section of the bowel completely removed, it takes care of the problems with the inflammatory bowel, but it does not mean that these extra intestinal type features of the inflammation will go away. Also, patients will have anal fistulas a lot of times with Crohn's because they develop fistulas in general, but you will see a lot of literature about perianal fistulas, which can be very problematic, as well as just the abdominal fistulas. And some patients end up having what's called narcotic bowel syndrome. They're just in constant pain, and they use so much narcotics that it makes the constipation worse and makes the condition of the bowel even worse. In terms of surgical management for Crohn's and UC, you do see this, sometimes they do surgery, but Crohn's generally they try to manage it medically and not do surgery until medical management's failed. And then for ulcerative colitis, if it fails, if they fail medical management, or if they're having severe complications, again, they may have a colectomy that can cure the disease by removing the colon, but it's not going to take the extra intestinal manifestations away listed above. This is just a little bit more information about fistulas, so you can kind of see. You get drainage directly from a perforation. Sometimes you get communication between two intestines. As fluid backs up, pressure builds up. You may see more leakage areas that can lead to developing peritonitis. And then that may also communicate actually through the muscle and skin wall, and then have a portal to come out of the body, and then you end up with the ones that we just looked at. These are the causes of fistulas. Believe it or not, 75 to 85% occur as a complication of abdominal surgery. So that's one of the main reasons that a lot of these inflammatory bowel diseases patients shouldn't really go to having surgery right away, is because they're putting themselves at a high risk for having a fistula just by doing that. And then you have 15 to 25% that kind of evolve spontaneously because of intra-abdominal inflammation or infection. These are just some other risk factors associated with fistulas: surgical procedures, having inflammatory bowel disease. If you've had a previous lysis of adhesions surgery done, or if you have peptic ulcer disease, it can make you at risk for any of these. Again, Crohn's and ulcerative colitis. diverticular disease, having had radiation, over the area of the abdomen, any other malignancy, even gynecological or pancreatic. History of appendicitis can create risk for having a fistula. Duodenal ulcers that have perforated, any other abdominal trauma, whether that be from knife or motor vehicle or gunshot wounds. And then if you've had a aortic aneurysm in the past or any kind of graft to repair that, you're at higher risk for fistulas to develop. These are just some more examples of what these may look like and typically how this might be managed in terms of drainage. And again, skincare is the most important nursing intervention for this. Occasionally you'll see some of these that if the infection is about cleared, they may put a wound vac on the wound to try to see if they can close it. But until they really get the full drainage out of it, it's best to keep it like a drain bag type thing and be meticulous about skin care and making sure that that bag really is adhered and really covering this area and not allowing any of that gastric acid to leak and erode the skin around there further. So this is just a little bit of background on diverticulitis. This is a small pouch-like protrusion or herniation. Sometimes, often in the GI tract. You see this more in the left colon. So you think about you've got your GI tract, and so you just suddenly have a little small pouched out protrusion of the intestine itself. We see this more in Western industrialized societies and in older people. In older people, it's likely because of the age of the colon itself and circulation to the intestines. That's not as good as it used to be, but also because of our diets are probably problematic for this. And men tend to have diverticulitis more than women. Occasionally, you'll hear this talked about as outpouching, and what happens when you get this little pouch that occurs, and this is not through the skin wall, but just like in the abdominal cavity and off to the side of the intestine, is that particles of food get trapped in there, causing what's called a fecalift. And what that is like this really hard material that forms like a really, really hard stool that's sitting in that pouch. And again, it's making it getting it inflamed and irritated. You may also see in patients' charts where you see the term diverticulosis. So diverticulosis is a situation where you've got these little outpouched areas, but they're not inflamed and not infected. If they're infected, then it's diverticulitis. And again, diet and age are a big issue. Lack of fiber, obesity, physical inactivity, and age greater than 60 or 65 puts people in the highest risk categories. So diagnostics for this is usually abdominal x-rays, CT scans. They also do pull your CBC and see what kind of white blood cell count you have to see if you're having infection or not. Usually uncomplicated ones can be treated on an outpatient basis with just some broad spectrum antibiotics. Patients may need to stay away from laxative and enemas. You don't want to create a situation that puts more pressure on the intestine. Pain medications can be given as needed. Usually, again, they're going to put them on a clear liquid diet until these symptoms subside, and then gradually, start full liquids and then kind of move up to more solids or soft foods over a few days, and as the condition's starting to feel better. Surgery may be required, like for a temporary colostomy, if there's a real problem area that has created almost a blockage, or it's just so inflamed it's not going to heal. And then they would take the two ends of the intestine and re-anastomose those later on, they would discontinue the colostomy, and then they would put the two ends of the colon back together. And sometimes this is real helpful for patients to know. Sometimes they might have a whole foot taken out of their intestine, depending on how much of an area is got this inflammation process. And so it can kind of change, but they're often comforted thinking that this will be a temporary colostomy and they won't have to deal with it as long until the healing takes place. Complications, of course, are perforations, abscess, and fistula formation. They can get a bowel obstruction and can have severe bleeding. And again, they can develop fistulas to other organs even from the inflammation kind of transferring over. Appendicitis, this is the acute inflammation of the veriform appendix. It's a common condition that occurs highest in a younger age group, so not as much adult health, but 10 to 19-year-old age group. However, there's much more rupture of this issue in adults than in the age group that it most affects. It does affect males more than females. It can also be caused from a fecal lift or another foreign body, but that is really kind of like built up in the appendix area itself. And it leads to inflammation and infection. And, the old wives' tale is that if it actually ruptures, that you're going to die. And that's not always the case, but it makes it a lot more likely that you're going to not do well in terms of risk factors and mortality. So the idea is to, when this is inflamed and infected, but before it bursts, to be able to get in there and take care of it. Appendicitis, as you know, is usually done as a surgical intervention, so there's no true medical management. If it's an acute appendicitis, they need to go in and remove it. So anytime you see those kind of conditions, you want to get a surgical consult quickly. Patient's going to be prepared for the OR to get an appendectomy. Again, laxatives and enemas are avoided. And appendectomies these days are done fairly easily just using laparoscopic surgery. Peritonitis we've alluded to throughout with some of these diseases because of the potential for rupture and leakage of contaminants and then subsequent infection. But just so you can kind of see a visual of what that might entail or look like, causing the abdomen to get very distended and or tender and rigid. You will have diminished bowel sounds, sometimes none at all, depending on how serious the condition is. There will be an inability to pass gas through the rectum or feces. Patients get tachycardic because they're losing fluids and developing infection, so the tachycardia is resultant from that. They also may have decreased urine output because they're getting kind of internally dehydrated because the fluid that is getting out of the GI system and into the intestinal wall is not really being taken up. So the key issue is very quick recognition on this, and you want to quickly notify physicians and start getting the patient assessed medically to get something done. Diagnosis, again, CBC may show that you've got some blood loss. It may show that your white blood cell count's elevated. They will often want to get blood cultures to see if you've become septic in your bloodstream. And then imaging tests, typical things you would see for abdominal. They may actually draw some fluid off of the abdomen and do what's called a peritoneal tap or a paracentesis, and then they'd send that fluid down for analysis in terms of infection and types of cells. Treatment is going to be IV antibiotics. Surgery is going to be done to repair the cause, clean out all the infection in there. So they're going to end up with an incision generally. So most of those are going to be done as an open abdominal surgery versus laparoscopy. And then the